Yeah, so I think if you look at the heart failure, there's a big, it's one of the, as you rightly said, it's the tip of the iceberg which we see. And if you look at the, uh, so can you see the slides? Well, yeah, so I think this is what Dr. Pradeep Jan was saying, that
Yeah.
myth and reality is, quite contrasting, and you can see that the problem is quite humongous. You can see under the water, the reality is that there is underlying structural and molecular abnormality, and the disease progression is silent and life-threatening. So if we, what Dr. Uh, Jan had asked that what is the, how big is the problem of heart failure. So if you look at the worldwide data, you could clearly see that, almost 37.7 million people are getting affected by this. And the burden is rapidly increasing. By 2030, the number of heart failure patients will rise by 25%. So that's again a very, very large uh, problem with the healthcare. And the other problem, which is, prognosis of these patients, are that 50% of them mortal they would die within 5 years, and it's a leading cause of repeated hospitalization, obviously draining a lot of resources. And heart failure represents 1 to 5% of total hospital admissions. So you can imagine 20% of patients who are coming with this heart failure admissions, 20%, almost 2 to 17% would die in hospital. So that's again a big burden on that. And again, the heart failure can be deadlier than many cancers. So this is again what I always tell my patients and public at large, that the reality and perception is quite different. You can see that people feel that probably the cancer would be bigger killer, but that's not true. You can see half of our patients within 5 years would not be surviving. So 5-year death rates are more deadlier than the cancer patients. And even, people feel that the mild heart failure should not cause much of an issue. I can see 34% of them would have, death if they are even in class 1 and 2. And then again, the 3 years mortality is 42% if they are in class 3 and 4. So meaning thereby, once the diagnosis of heart failure has been made, we need to be really, really watchful because the serious complication issues. And the very, very contrasting Indian data where the disease is happening pretty early. You can see at the age of 53 years compared to 73 years in Western and global data. And in hospital mortality in India is almost 8 to 9 times more, 3.8 global data versus in hospital mortality is almost 30.8%. And post discharge mortality is again 3 times than the global data. In India, 6 months discharge mortality is almost 27%. So the patients in India with the heart failure are much younger and have got a higher mortality. So over to Dr. Piyush, that this is what the data suggests, that how big the problem is.
Yeah,
Dr. Piyush.
like you said, it's a huge problem, and the mortality and morbidity is very high. And we have a lot of conventional drugs in heart failure, like ACE inhibitors, ARBs, beta blockers, diuretics, spironolactone. Which improves survival. So,
Mhm.
what was the need of a new class of drug which are being used nowadays most often?
Yeah. So
Dr.
again,
Viveka, please.
yeah. So again, you could see that we had already so many drugs, and you can see this chart clearly shows that, especially unlike heart failure with preserved rejection fraction where we don't have any option as yet, but with the reduced rejection fraction, we had ACE inhibitors, beta blockers, MRAs, and all these ARBs and ivabradine. And you can see that they were doing reasonably okay. Almost beta blocker had 34% relative risk reduction in mortality, whereas MRA also very impressive 30%. ARBs again 17%, ivabradine in SHIFT trial had 19%, and ACE inhibitor 16%. So despite the conventional therapy, there was a what we call the residual risk was there, and that gap was not being filled. And there is 50% mortality rate for heart failure patients, as we said, in 5 years post diagnosis. So this gap, was recognized quite early, and you could see that the natriuretic, we recognize that uh, natriuretic peptide is something which is very good, and that body naturally, you know, secretes it. What it does is that decrease the blood pressure, sympathetic tone is lesser, the decrease in vasopressin, aldosterone goes down, fibrosis is lesser, and hypertrophy also comes down. And then we already know the RAS system, sympathetic nervous system. So these things which increases the RAS activity, vasopressin, increase the heart rate, increase contractility, in turn leading to high blood pressure, high sympathetic tone, hypertrophy and fibrosis in long term, which is very, very harmful. So we needed a thing which could work on this and decrease the adverse outcome. So this new drug, which is not so new right now, but still it's like a new tool in the armamentarium of medical management of heart failure. So the ARNI shows better decrease in overall mortality. So whatever we had, good with the optimal medical treatment, on top of that, this gave us almost 22, 21%, decrease in mortality. And you can remember that the mortality is one of the most hardest endpoint which came down. And not only mortality, but also, the hospitalization rate, improvement in quality of life, and all those things were much better with this new molecule. So that is why I think there was a felt need, and fortunately we had a molecule which filled this gap. Yeah, Dr. Chen.
Yeah, I think that's very true. The mortality reduction has been very much better with this new class of drug of ARNI. And what do you think is the mode of action of this drug, which is different from ACE inhibitors and ARBs, which is leading to all the mortality and morbidity benefits? Dr.
Yeah,
Viveka?
so I think, so I think, Dr. Jan, we had discussed it so many times that
Yes,
there
yes.
was a disequilibrium of neuroendocrine balance due to the heart failure. In chronic heart failure, that is where it has been licensed to be used, and now gradually with the in acute heart failure also. But you could see that the ANP and others are good molecules, but they were not in high quantity. And it was the bad molecules which were shifting the balance in, tilting the things into an adverse outcome. So neprilysin inhibition was a novel therapeutic strategy. You can see this is the place where it works. And there was, pro-BNP to BNP and then BNP into inactive ingredient. So what it did is that it blocked here so that the blood pressure comes down, sympathetic tone comes down, aldosterone level comes down, cardiac fibrosis and hypertrophy comes down, even necrosis comes down. And on the other arm, when the bradykinin degradation was decreased with the neprilysin, then again the nitric oxide was improved to improve the endothelial dysfunction. Natriuresis was also improved to decrease the load. So when you add ARNI, the effect, what it does is that it causes more vasodilation and dialysis, and then it causes uh, so ANP and other factors are the good things, counterbalances the bad things. So beta blockers and valsartan alone was not able to do because you are using more of ANPs to improve the balance. So when you give so the basic difference is that it sets the equilibrium in such a way that the beneficial effects are much better, and so that the vasodilation and diuresis happens more, potently. So this is what the combination of this naproxen and the uh, RAS blockade would do. So in turn, this neurohormonal balance, which has to be brought down to a beneficial level, and that is how it is different. That what we were not able to achieve with ACE or ARB alone can be achieved with the ARNI, that is sacubitril valsartan combination.
Yeah, very well put up, Dr. Viveka. Since we are at it, if you could just highlight on also what are natriuretic peptides and how do they have beneficial effect in heart failure for better management?
Yeah, so I think it's we need to understand that why it is so important, and that why the nature allows it to be secreted in heart failure patients. So this is natriuretic peptide has a potential beneficial effects in heart failure, release of ANP and BNP from heart, and CNP in the vasculature is there. So what it does is that decrease in sympathetic outflow, decrease in vasopressin, salt appetite, and water intake goes down. Sodium and water loss is there, so that the fluid retention goes down. decrease in aldosterone is there, and renin also goes down. So neprilysin degrades the natriuretic peptide and other substances, including angiotensin 2 and vasoactive peptides relevant for cardiovascular physiology. And in turn, if you look at the physiological effect, that is, for the long term, the hypertrophy and fibroblast proliferation is inhibited and decreased. And for the hemodynamic benefit, we see that there is a vasodilatation, systemic vascular resistance goes down, coronary artery pressure goes down, as we know that how important it is, and the
Sir,
wedge
sorry
pressure
to
also goes
interrupt.
down. Yeah.
It's the time to conclude it, please.
Okay, so I think these are the
Actually,
things which are important, and I would request Dr. Jan to,
actually, we
conclude the
started very
presentation.
late.
Yeah, yeah. So I think,
Dr. Jan, you need to go to
Yeah.
Dr. D.K. Agarwal now.
Yeah, Dr. DK is a nephrologist with us on the panel, and one question is how the natriuretic peptides affect the kidney function. For Dr. DK Agarwal to comment on that, please.
Good afternoon, Dr. Khanna. Thanks for calling me and giving me a chance to discuss this problem, very important problem, Dr. Jain and Dr. Viveka Kumar. See, I will tell in short that there's all the things, cardiac as well as renal, they are interrelated. They may not be apparent on your practical test like urea creatinine, but when you see the GFR, when you see the macroalbuminuria, they are interrelated. That is why the cardiorenal syndrome is there. And many of the patients, they are having both involvement, and the pathway of both are same. There's a activation of the RAS, and there's a vasoconstriction, sodium retention, and water retention, and leading to failures as well as hypertrophy and fibrosis. Natriuretic peptides, they are very good because they lead to afferent vasodilatation, and then they lead to increase in GFR. They lead to reduction in the blood pressure, aldosterone comes down, and the sodium, which is excreted, is not absorbed from proximal convolutive as well as distal convolutive, and the water is not very much absorbed from the distal convolutive because of vasopression. So all these effects are there. These are the good effects of atrial natriuretic peptides, and sacubitril that we are giving, that preserves that effect. And if you see, the another aspect is RAS activation. So what RAS activation comes, it preserves sodium and preserve water. What this natriuretic peptide does, they take out the water and sodium. So it is like more intake and less output. But when the less intake, more output, the things are benefited.
Thank you, Dr. Agarwal. While you are there, and since time is short, maybe we would ask you what is the role of ARNI in patients with chronic kidney disease? Should we give in them or not, and how to modify their doses?
Yeah, that is a very good question, and the question of the hour also, because I said most of the patients, they are having both involvement. Either it is apparent, it is not apparent. So ARNI, first of all, it can be given to all patients. The only thing is, if the GFR is less than 30, stage 4 and 5, we have to be cautious. And there is no firm guidelines, or there's no firm structure we can frame for these patients, because they behave separately. So it is individualized. And when we are having low GFR, then if you see the study paradigm HF, that the benefit of mortality is there, ESRD is reduced by 30%, and there is a reduction of GFR, which is very less, and the creatinine, which is less than other side, enalapril. And there is a potassium, which is not very high. Severe hyperkalemia was not there even with MRA, when you have MRA enalapril and MRA sacubitril or ARNI. So these drugs we have to use. These are very good drugs, very cautiously, and keeping a watch on potassium, albuminuria, proteinuria, and GFR. These things we have to take in mind in every patient. And you have to initially keep a watch on potassium every twice a week or weekly. Once patients are stabilized, you can do fortnightly or so. And then creatinine weekly, first 3-4 weeks, to see if there's a very low GFR, acute on CKD, high creatinine is going on. Otherwise, you can do 2 to 4 weeks or every monthly, like that.
Thank you. Thank you. So, Dr. Vivek, another question. So, if you have a patient with stable heart failure on current therapy and not on ARNI, would you today like to switch over to ARNI in these patients? And do you think this would help in quality of life and even survival?
Yes, I think that's a very brilliant question. Let me tell you that, when we see the data from class 1, class 2 patients in heart failure, there also the mortality reduction is significantly better with ARNI. And then one most important thing is that the patients who are in class 2 and 3, they have got more cardiac arrest than patients who are in class 4. Switch over to ARNI so that they get the maximum benefit of survival and the benefit from hemodynamic changes because of this molecule. So the answer is emphatic yes, and obviously that's the reason why the guidelines are also coming in that direction that we should do that way.
Thank you, Dr. Viveka. Thank you, Dr. Agarwal. In paucity of time, you have delivered the message of role of ARNI in heart failure, stable heart failure, and also the precautions and to be used in patients with kidney disease. Thank you, Dr. Khanna. Over to you.
Thank you, Dr. Jain.
Thank you.
Thank you so much, Dr. Jain, Dr. Viveka, and Dr. D.K. Agarwal. I'm very grateful that you had to stop your work and for this lecture, all three of you, and especially Dr. Jain for conducting such a good program and discussion. So thank you all very much, and we'll move on to the next session, which is on cardiovascular update.